And welcome back. And we are moving into our final segment for today as we discuss a little bit about what you offer, Dr. Constanza, as a pediatrician and neonatologist. Good morning and welcome, and thank you for being here.
Good morning. Good morning to both of you, and happy Women's Day too.
Thank you.
Okay, I was hearing the conversation. It was very interesting.
Yes, and I'm sure you can tell us a little bit about what medical school and working in the hospitals is like as a female professional.
Well, as a female professional, of course, we face challenges sometimes in shifts and so forth. Yeah. It's more, when we talk about challenges, maybe it's more physically tiresome, no?
Yeah.
For a female to do things that maybe a male professional, doctor can withstand more. You know?
Yeah.
So those are the things like that.
So, Dr. Constanza, let's talk a bit about your specialty. You're a pediatrician, but you're also specialized in neonatology. What does that include?
Yeah, neonatology is a subspecialty of pediatrics.
Yes.
Okay, in pediatrics, you need to do pediatrics first.
Yeah.
Okay, and then further specialized, depending on which country you are. You know, the curriculum. Some are two years, some are 3 years. You further specialize in newborns, but it's not only specifically newborns once the baby is born, because we do as well in our curriculum perinatal, a little bit of perinatal, fetal medicine, and neonatal. Okay, so we also study some perinatal aspects, some pathologies in the pregnant woman, and how that pathology impacts the baby, you know, in the growth and development of the fetus. Okay, so once the baby is born, we can already, you know, foresee this baby will have this and that, you know, and so forth.
That's interesting, because I think I don't know what women who are pregnant do these days. We have a fairly good record in terms of women accessing clinic care, but we know that other than ultrasounds, there isn't a whole lot of investigation into potential effects a child may have. In the States, for example, some people do genetic testing and they do other kind of tests to find out how healthy their baby is going to be. What's the standard in Belize? I know you do some work with KHMH, right?
Oh, okay. I was, you know, at KHMH. Well, as a neonatologist, I've seen that yes, we have a lot of deficit when it comes to other exams that the baby, you know, requires, or even the pregnant woman would require, you know, to further do some screening, you know, in the fetus. Baby. So yes, we do have that limitation here in Belize. Some people would send samples outside, you know. But yeah, in that case, we do need to work hand in hand with gynecology and obstetrics. Okay, because they are the ones who do the follow-up of these women. Okay, and especially if it's a high-risk pregnancy. Those are the cases that should be consulted with a neonatologist, you know, and these are the cases as well that at some point, if the pregnancy needs to be terminated as a C-section, early C-section and so forth, then of course it's something that should be discussed with a neonatologist as well. That's what neonatology, you know, more or less includes. We do fetal, so we do all that congenital malformations and so forth, infections, be it congenital as well, not only in the neonatal period, but congenital infections. So if mommy has toxoplasmosis, cytomegalovirus, rubiola, and so forth, you know, we already know
the kind of diseases that you know
the
will
baby
impact the
can,
baby.
yes, and what the effects with the baby will have. So we do take care of newborns. So when we talk about newborns, a baby is born from 0 to 28 days, the first month of life, yes. So people might think neonatologist is only for preterm babies, And no, not specifically.
Yeah.
Okay, we do deal a lot with preterm babies because the prematurity is a big content, that we have to work on. But we also deal with term babies, healthy term babies that we do as well the follow-up of these babies. Okay, so it's for both all type of babies, newborns.
Dr. Elsie, let's look at what constitutes a high-risk mother and some of the potential challenges they may face.
Yes. Well, a high-risk mother, high-risk pregnancy, I would say. For example, it's a mom with hypertension or pregnancy-induced hypertension. If she doesn't take care of herself or she doesn't go to clinics, that's the importance of prenatal control. To detect and control as well the pressure, because then it might just go on and do preeclampsia and then eclampsia, and it would reach a point that maybe the baby or the fetus would be compromised, at some point.
So high blood pressure before or developed during pregnancy makes it a riskier pregnancy.
Yes. Yes. Okay. So those we see a lot of cases here in Belize of moms with preeclampsia or a few with eclampsia. Eclampsia is like the other stage, and those pregnancy, they need to be terminated in emergency. They finish as an emergency C-section, and the baby sometimes is premature. The gestational age of that mother is early yet. So those are the things we need to take care of those babies. So we already focus. Mommy had been with pressure all the while during pregnancy, so we know already that placenta and the umbilical cord have been compromised. So we know that baby could be intrauterine growth restriction, a lot of things that can cause that has impact on the baby. Those are high risk pregnancies.
So hypertension is one. Diabetes
is another one.
Okay.
Of course, diabetes, and the same thing happens with diabetes. We have pregnancy-induced diabetes too.
Yes.
So once we know, the history, mommy is diabetic. So we know already, what the impact of that diabetes can have on the fetus, and then on the baby once it's born, and so we have to take care of that baby, take care, for example, of his glycemia, her glycemia, the baby's glycemia, sugar level, and platelets, calcium, because they do a lot of metabolic disorders too, and these babies can't be large for gestational age. So it's
which tends to be one of the major possibilities with diabetes while you're pregnant, right?
Yes, being a large for gestational age, and if it's a vaginal delivery, the baby has risk as well of doing any perinatal asphyxia or any lesion, obstetric trauma too, because your babies, large babies. So it's a lot of things that we have to put in together.
Before the baby is born.
Yes. Before the baby is born, knowing mother's history. So it's important. Those are high risk. High risk if mom is with hypothyroidism or hypothyroidism too. If mom HIV moms, any kind of infections. Mom had hepatitis. Hepatitis B. If mom has infection, urinary infection, recurrent urinary tract infection too, there's a risk in the baby as well of a risk of infection in the baby. And
what about age factor? At this time, when a lot of people are starting to have children at a later age than they used to, what is the age that a mother becomes high risk?
That's important too. The age. We have the two extremes. So less than 18 years, high risk, an adolescent, and then more than 35 years makes you already a high risk patient.
So this would mean you definitely want to follow up not just with your gynecologist, but with your neonatologist to ensure that things are on target for the baby.
Yes, of course. I try to encourage and campaign more or less that, you know, we need parents, we need pregnant women to continue their prenatal control, to do a prenatal control, you know, and everything depends on the quality of the prenatal control too.
Yeah.
You know, but they need to do that, and then the obstetrician should, you know, work hand in hand with a neonatologist.
Yeah.
Just that this field of neonatology is new here in Belize.
Yeah.
Okay.
You are the only specialist currently in country?
Yes, yes,
Wow.
yes.
And Belizean too. I love that.
Yes.
Yeah.
I'm the first Belizean neonatologist here in Belize. We have at this moment 2 neonatologists. They're Cubans.
Yes.
They're Cubans neonatologists working in Carl Huchner.
Yes. Now, this is, and that's why I wanted to touch on that just a bit, because whereas women are used to, or expecting parents are used to visiting the clinic and used to visiting their gynecologist, how do you help to educate Belizeans as to what the role of a neonatologist is and how it can improve the health and overall well-being of their baby when they're born?
Okay, yes. That's a challenge here right now in Belize, since neonatology is something new here.
Yeah.
It's not new in any other part of, you know, of the world. In other countries, you know, neonatologists do work hand in hand with obstetricians or even perinatologists. Perinatologists, they study the fetus. So they are obstetricians who study the fetus, you know, and so forth, and pathologists. So we would work hand in hand with an obstetrician, especially when it's a high-risk pregnancy. The thing is that that's the norm outside, but here in Belize, since it's new, at some point, it's the pediatricians, you know, who have been doing that sort of things, no, with the obstetricians. But being a neonatologist, of course, we see things more in depth. You know, it's a specialty by itself, and we need to know everything from mom's history to how we see the baby at birth, okay, and do a comprehensive examination, physical examination on the baby, because sometimes by just seeing the baby, you know, examining the baby, you can think about pathologies, you know, and then how, you know, what we need to continue a follow-up in this baby according to what you see and so forth. And it's important for a neonatologist, because we do, of course, need to continue the growth and development of this baby, especially in preterm babies. A premature baby born at 28 weeks, for example, we must continue continue the growth and development, the care of this baby as how it would have been inside mom, okay, in the womb. So that's what we need to guarantee is a temperature, you know, correct temperature. That's why the incubators exist. You know, the humidity in the incubators that help them too, and we need to continue with your nutrition, because remember, the fetus
was being fed by mom.
Yes, by, you know, by the placenta through the umbilical cord. So once that's cut, we need to continue the nutrition on these babies, and that's very, very important.
And the nutrition that they need for the type of development they're going to undergo.
Yes, of course. We can see if you are giving this baby the adequate nutrition, complete nutrition, especially in preterm babies who would require parenteral nutrition, which is nutrition, how can I say, by the vein, you know?
Like through IV.
Or through any central line, no? Okay, that's very important, the parenteral nutrition, but it needs to be a complete parenteral nutrition, because everything we put in that nutrition, okay, be it carbohydrates, fatty acids, or lipids, vitamins, okay, and other trace elements, calcium, okay, those things have an impact on the baby's growth and development, because the brain at 28 weeks is small. It's almost soft, it's like soft surface, but they, you know, as they grow and they need these elements, this type of nutrition, the brain starts to continue growing, and then it starts to form, you know, the gyras, and then how we normally know how the brain looks.
The more fully developed brain.
It continues growing, and according to the baby's postnatal age. Okay, and remember a child's brain, they continue growing, and they reach adults, more or less brain, the mass around 5 to 6 years. So it's important. We need to take care of all of this in a premature baby. We need to continue the growth of this baby, how the baby is gaining weight every day, and how the baby's head circumference is growing. That would tell us a lot of things, as well as the length of the baby. So those are many things that we need to continue focusing on.
Let me ask you a question. What prompted you, Dr. Elsie, to move into this very specific subspecialty? You had experience as a pediatrician, and then you decided to go into neonatology. Why was that?
You see, I did. I guess I liked it. Ever since I liked neonatology, since the general, medicine, and but then I did pediatrics. I love pediatrics too. And the hospital where I did pediatrics, the University Hospital of Caracas, it's part of the Universidad Central de Venezuela. Okay. After I finished pediatrics, they offered me, to do a subspecialty, and they offered me the neonatology, and I was interested in neonatology too. I wanted to do neonatology because I like it. And and that's how I got to do neonatology,
as your subspecialty.
As my subspecialty before.
It's such a delicate practice, as you pointed out. When you think of, anytime I think of preterm babies, where we have the images of these tiny little humans in an incubator that really should have been in the womb, it just seems to be such a sensitive field. I want to ask you if there are things that perhaps, or practices that you see in Belize that are putting our babies at risk, just because people perhaps aren't aware of what they can do differently, that you would love to see changed, or access, or that they would access care to better the chances of the quality of life of their children.
In that case, I think we have to work on the prenatal controls.
Okay. And when you say prenatal controls, what do you mean?
Prenatal controls, I mean that women should, be educated to do their prenatal control, not only to start prenatal control, but to start and finish their prenatal control, to do it completely, and to do it on time, to start on time, because we have a lot of women who book late. And sometimes it's already late for us, for the obstetrician as well, to do something. So I think it's a part of educating women right now, and we are seeing too a lot of pregnancy in adolescents. That's a risk factor, and these adolescents, this age group, has a tendency of having premature babies.
What are the risks associated there? The body simply isn't ready, or?
So most of the time, yes, the body isn't ready, okay? And sometimes the care too, the prenatal care, okay? The infections and so forth, that way you need to take care of during pregnancy. It's not really done quite well because of the prenatal control that is not followed. Yes, we need to target these age groups, these people, Other thing that I've seen that what can be done differently, that can change, is once that the baby is born to, we should encourage more breastfeeding. More breastfeeding. That has a lot of effects on the baby. It does help a lot on the baby's immune system too, and prevents lots of morbidities on the baby. Okay, so I know many people work too. They tend to give the baby any formula, but then it's not any formula that you can give your baby. And
so you really want to see more breastfeeding taking place, exclusive breastfeeding,
up to 6 months. Exclusive breastfeeding up to 6 months of life. And another thing in care, when we talk about care, maybe It's now comes as a national level, maybe to have to improve maybe the transport system or something like that, you know, for babies, critically ill patients, babies, you know, transferred to another center, you know. So it that needs to as well, you know,
be strengthened.
Yes, yes. And another thing which is very, very important, and I always stress it, you know, on the patient and mom, is that once we discharge your baby, okay, that's very important. We, you know, for example, this baby born 28 weeks or less with 700 grams, you know, these are the babies who would go through a lot of complications preterm babies would go through. Okay, but they would survive. They would be in NICU around 2 months, 3 months, but that's the care we did there, you know. But then at discharge, when you discharge these babies, the care should continue at home with mom. Okay, and we need to stress that because sometimes that care isn't enough, you know, isn't enough, and then it's when we see complications in the baby is not fed as how it should, you know.
Proper nutrition.
Exactly. And then baby gets sick, you know. These are the babies who will visit the hospital at every time, you know. So the care must continue at home. And I do as well congratulate parents who do take care of their babies, and they go and they go to the follow-up clinic too, you know, because it's important. I tell them, please come to the follow-up clinic of your baby, because once your baby is discharged, we need to see your baby at 7 to 10 days of life. Okay.
To monitor their progress.
To monitor their weight gain and everything, all progress in general, no? And then we continue monitoring these babies monthly. Because these babies they are discharged, they go home with a low birth weight, with 1,600 grams, you know, 1,600 grams.
Still tiny.
It's a very tiny baby, but you know, they go home like that. So we need to monitor these babies keenly, you know, very closely. And to do that, well, we need parents to put their share too, you know, and take care of these babies.
So, Dr. Constanza, you've returned to Belize and you're moving into private practice at this point. Where can people get in touch with you or visit your clinic?
Okay, yeah, I have a clinic at Belize Healthcare Partners Limited. Okay, my clinic is Mondays, Wednesdays, and Fridays.
Okay.
I'm doing every other Saturdays too.
Yes.
So it depends. Okay, but it's every Mondays, Wednesdays, and Fridays.
Okay.
From 8 o'clock up to 5, depends, you know, if 5 o'clock more or less. So that's the clinic we are doing right now. And
at what stage in their pregnancy should a mother reach out to you? An expecting couple reach out to you?
Okay. It should be the obstetrician.
Yes.
Okay.
To refer.
To refer.
Okay.
Or to discuss the case, you know, with me, with a neonatologist. And of course, if you know that I'm there, you know, you can ask. You can say, you know, I would like my case to be discussed with Dr. Constanza and so forth, you know. And because it's something that the prenatal control is done with obstetrician, just in case that the obstetrician might see it's a high risk, you know, pregnancy. Then they can consult, you know, and see what we can do, and whatever suggestions, you know, we can offer. So and then once the baby is born too, you know, at birth, okay, we at high risk pregnancies, then we are, you know, the ones to be there to receive the babies and see, you know, how the baby will be born and what can we do, you know. So those are the things that we do as well.
And then after the baby is born, of course, you do have pediatric services available.
Yes, afterwards, afterwards pediatric services. But you know, for example, in preterm babies, there's a high risk group of neonates.
Yeah.
And these in this group, we have premature babies. We have babies with congenital malformation. Okay, babies who might have jaundice and required blood exchange, transfusion. Babies who require some major surgery.
Yeah,
okay.
at a young age.
Yes, at the neonatal age. Babies with birth weight of less than 1,500 grams, born less than 32 weeks. These are all a group of high-risk babies, no, that we must continue follow up with them.
Yeah.
Because what I've seen is that these babies, as I told you, we discharge them with 1,600 grams.
Yeah.
But then, okay, what formula do we give these type of babies? Then at home, of course, first breastfeed, no?
Yeah.
But then we need to try to give these babies a formula that is rich in calories.
Yeah.
That's why there is in the market premature formulas. Okay, premature formula has more calories.
Yeah.
So we try to combine and give the baby as well premature formulas. But then it's not giving the premature formulas until they reach 2,500 grams. Because 2,500 grams is already a normal birth weight.
Yeah.
Birth weight. But then if you see this baby who was already 3 months, okay, it was born way premature.
Yeah.
Discharged at 1,600 grams would have already a postnatal age of let's say 3 months already there.
They need to hit their 3-month target, not birth weight.
Exactly.
Yeah.
But then if you see at 1 month, just saying 2 months, they would reach to 2,500. But then reaching 2,500 now at 5 months is not normal. It's not good. Okay, because we have some charts.
To use,
some charts we use for premature babies, especially for premature babies. So these babies still continue to be undernourished, or okay, and we need to continue that formula, even though they have more than 2,500. We need to continue that formula, see how they grow until they do the catch up. What is the catch up? The catch up is that they reach, then while they are growing, yes, they reach to a point that they have, let's say, 9 months. Because a lot of babies I've seen, they do catch up around 8 months. Some less, a little bit less, some more. But around 8 months, now their weight at 8 months, their length and their head circumference at 8 months, being a premature baby, has been, in the normal range.
Normal development.
Yes, like a normal baby. Yeah.
Well, Dr. Constanza, we're so grateful to have you in to talk a little bit about what your specialty provides, and we really hope that people will be able to access the services, especially when it comes to high-risk pregnancies and, of course, any follow-up care that is meant to come. So once again, you're at Belize Healthcare Partners, Monday, Wednesday, and Fridays.
And then I'm also at Northern Medical Plaza Limited.
Okay.
Northern Medical Specialty Plaza Limited.
Okay.
I'm on there on Tuesdays and Thursdays and every other Saturdays too. Okay. So yeah, my Saturdays, I depends, sometimes I have patients there and they call me, small babies and so forth. So I'm every other Saturdays and sharing between the Northern Medical Plaza and Belize Healthcare Partners Limited.
So people in the north can take advantage of your services as well. We want to thank you for stopping in.
Thank you. I want to close what we are doing right now at Belize Healthcare Partners. We are doing a promotion, okay, on Wednesdays. Okay, for my clinic. We offer 50%, okay, discount, but for all moms who take their newborns, okay, babies from 8 to 10. Okay, so it's strictly for newborn babies. It's not for pediatric patients.
Yeah.
So it's for newborn babies.
So don't bring your 5-year-old.
Yeah, it's strictly for newborn babies.
Yeah.
And
Any baby within the first month of their life.
Yes. If they take them Wednesdays, it's Wednesday mornings from 8 to 10. So they get a 50% discount.
Well, thank you very much for coming in and sharing all this information with us.
Thank you to Jamie.
All right, we're going to go ahead and take a break, and when we come back, we'll have our wrap-up, so stay tuned.